Hello, everyone. In this revision lesson today, we'd be discussing this question from May-June 2024, paper 3, variant 3-2, question number 4A, 4B, I'm sorry. Question number 4 has to do with description. So if you talk about this particular question, which is a 10-mark question, reads, evaluate ECT, that is electroconvulsive therapy, and CBT, that is cognitive behavioral therapy for the treatment and management of schizophrenia, including a discussion about the ideographic versus nomothetic approach. So when we talk about ideographic versus nomothetic approach, number one, understand when the examiner writes down, including a discussion about, dash, whatever that, this could be anything. This is, in this case, it is ideographic versus nomothetic. It could be anything else as well. So whatever it is that is mentioned in the question, you refer to that as the named issue. And the named issue is, it could be a named issue or named debate. This is what the examiner expects you to cater to the most. Now, additionally, after 2024, the examiner has been a little more specific when they write down evaluation in your answers can include strengths, weaknesses, and a discussion of issues and debates as well. So about ideographic versus nomothetic approach, there are two elements that we are talking about over here. So that automatically makes it a debate. Now, before we proceed, we need to revise what the differences between ideographic versus nomothetic approach. As we speak about ideographic approach has more to do with how something has to do with an individual, right? So when you talk about case studies are typically considered to be ideographic. However, when we use the word nomothetic has to do with something that is more generalizable, that is more applicable towards all. So just in case if you fear getting confused or mixing them both up, I for ideographic, I for individual, a single individual, right? Whereas when you talk about nomothetic approach, this has to do with something that is applicable to all. Now, taking this a little further, if we start off with the named issue, the named issue over here is ideographic versus nomothetic approach. Now, about this specific question, I'd like to take the opportunity to explain you one more thing. Now, you see in this question, you have ECT as well as CBT, both that are expected to be catered to. And at the same time, there's a debate over here, a debate between ideographic versus nomothetic. So wherever you think you can, wherever you think there is enough of content, try catering to all of the elements, right? So especially when you talk about debate, for instance, ideographic versus nomothetic, or the nature versus nurture debate, or free will versus determinism, whatever the content is that you are evaluating, right? Whatever the content is that you're evaluating, try gauging it in terms of, or try scrutinizing it or evaluating it in terms of both elements of the debate. So as we speak about ECT, we'd initially talk about how ECT could be nomothetic as well as how ECT could be ideographic. And at the same time, when we'd be discussing cognitive behavioral therapy, that is CBT, I try to see how it is nomothetic and ideographic both. Now, to begin with, ECT follows a nomothetic approach, as the general law is that all patients will experience a seizure and this will lead to an improvement in symptoms. That's the principle around which ECT revolves. The idea is that you're passing electric current so that the individual in a very controlled and supervised environment experiences a seizure. So it's a seizure that the therapist is looking forward towards, not electric current. So we're just using electric current so that the patient could experience a seizure in a, I'm sorry, in a well-controlled, supervised environment. So ECT follows a nomothetic approach, as the general law is that all patients will experience a seizure and this will lead to an improvement in symptoms. However, it also has an ideographic element to it, because guess what? ECT, while studying ECT, it is important that we also do recognize that it may not work for all patients. Like ECT might work for some patients, not all. The amount of time a patient requires ECT might vary. The different sessions that a particular patient might require might vary too. The extent to which one patient experiences side effects might be different from the extent to which another patient experiences side effects. So we just tapping into both the nomothetic and the ideographic elements over here. Moving on, if we talk about cognitive behavioral therapy, that is CBT, this is somewhat nomothetic. Why is it that we're saying that it is somewhat nomothetic? Because it has a general law, right? General law, something that is generalizable, applicable, or made for all. So CBT is somewhat nomothetic as it has a general law that the therapy is beneficial due to a therapeutic relationship developing between the patient and the therapist. And the therapist helps the patient restructure the cognitions with a focus on goals and problem solving. So the general principle behind cognitive behavioral therapy is that it is something that would be applicable for all. It's just about the rapport being built between the patient and the therapist, and the relationship that is being built between the patient and the therapist would help the therapist restructure the cognitions, the illogical, irrational thoughts of the patient while focusing towards problem solving. However, at the same time, it is also ideographic. Now, I really like this word, however, being used over here because, you're showing the examiner that you are catering to both ends of the debate, right? Now, however, it is also ideographic as the goals, problems, cognitions will be unique for every patient. Now, if one patient has a goal, this goal might differ, this goal might differ for another patient, right? So the problems that one patient has might be different from the problems that another patient would have. Now I hope you've understood this named issue. Along with this named issue, we are expected to write down about two more issues. It could be issues, could be debates, could be strengths, could be weaknesses, anything. So number two, let's move on and write down about experiments. I mean, it could be experiments, it could be something else as well. So if you want to write down about experiments, try recalling the researches, be it a key study, be it an example study from your syllabus, right? From your syllabus, because over here you see this word Sensky study written. The examiner is assuming that you're aware that your syllabus, your syllabus under the heading of cognitive treatments did have an example study that was conducted by Sensky et al. So, for example, if you talk about Sensky's study was an experimental design. I mean, this doesn't make much sense, but yeah, it was an experiment with a lot of controls. This makes sense now. This was an experiment with a lot of controls, which of course adds on to the value of the study. Controls over what? Controls of the length of the treatment, blind raters, of course, if the raters are blind or if they're independent, not blind, but if they aren't really aware of the conditions that the participants are going through, that adds on value, that improves the internal validity of the study, that improves the credibility of a particular study. At the same time, this particular study had good ecological validity, right? Because this study was conducted on real patients. At the same time, when you are randomly allocating participants to different conditions, that removes the chances of researcher biasness affecting the research, and it, like I say, adds on value to the research. But then again, for you to evaluate in terms of experiment, you should be well aware about the syllabus for about your you should be well aware or well acquainted with the syllabus. Now I just remembered I have some content on Sensky over here. This is exactly the marking scheme. If you do not really recall the study by Sensky, you might as well pause it over here and give this a quick read. We are just reading through this real quick. I mean, I want you guys to read through this real quick. This is the descriptive part, right? So this is the descriptive part. That's a disclaimer here. I'm just highlighting this so that you could read it real quick and see what particular parts from here can be possibly used when it comes to evaluating this study. Now, remember the study by Sensky in the year 2000. This is not a key study. This is an example study. So as this is an example study, you should know that you cannot get a direct question that has the name Sensky et al. Mentioned in it. Yes, the examiner could phrase the question in a manner that you might be expected to use the knowledge from this that you've gained from this particular study, but no specific question that says describe, let's just say describe the study by Sensky et al. Or Sensky in the year 2000. You would not get a question of this sort as long as we have the current paper pattern and structure. Now, moving on, another way through which you can evaluate this study. This is a longitudinal study. Because this is a longitudinal studies, right? So the strengths of using longitudinal studies, they show change in behavior over time. The study by Sensky investigated changes in symptoms over a 9-month period. They're often in depth as time to collect they're often in depth as there's a lot of time to collect data. Remember, we're talking about a longitudinal study. A longitudinal study is a study that is conducted for a long and extended period of time, provided there are developmental changes recorded. Developmental changes being recorded. So, number 3, you could refer to this as being holistic because it helps you develop a thorough understanding of the participants in the study because of the amount of time you're spending. No recall bias, as the participants don't have to remember past events, because remember, when you talk about a longitudinal study, there is periodic data collection. This periodic data collection, I mean, you could decide when to collect data so that the participants do not have to recall things from the past. I mean, you could collect data after, let's just say, bi-weekly or monthly or quarterly or in 6 months. So yeah, taking this a little further, there are certain weaknesses of longitudinal studies as well, and these are pretty generic weaknesses that you could, of course, through or by applying to Sensky study, put to use while answering this particular question. So if I talk about the weaknesses of a longitudinal study, to begin with, they're more time consuming, they require a lot of time. Sample attrition, what does the word sample attrition mean over here? The chances, the possibility of you losing on your sample because of the amount of time that is required. In some longitudinal research, participants drop out of the study due to a loss of contact, unwillingness to continue, etc. Researchers can develop a close bond with the participant and can be less objective in interpretation of data. Of course, because of the amount of time that you've spent with the very same group of participants, there's a possibility you built a rapport with some, you might start liking some, you might start disliking some. Researchers, by the end of the day, are human beings. So the likelihood that the close bond that you develop with the people you are supposed to collect data from might end up affecting your research. Now, moving on towards the third evaluative point that could possibly be used, again, generalization from findings. See, for this, you had to be familiar, you had to know the study that was conducted by Sensky. You cannot evaluate a study without knowing that study. So Sensky study was done on 90 patients, 57 from clinics in Newcastle, Cleveland, and Durham, and 33 from London. They had diagnosis of schizophrenia that had not responded to medication. The age ranged 16 to 60 years. Now, this shows us that there's good generalizability of findings because of the diverse data you have. So I'm sorry, let's go back here. Yeah, so here, here, look at where all you've collected your data from. Look at the amount of clinics, look at the age bracket over here. So you could conclude that the generalizability of the findings of this particular research are pretty decent enough. Moving on, you can discuss issues with not generalizable to patients who have responded well to medication but might still benefit from CBT. So because we were talking about patients over here who had not responded well to medication, so your findings are again only restricted to these sort of patients and not everyone. Moving on towards another to another issue that could be put to use for evaluation, and this is ethics. With some schizophrenic with schizophrenia, some treatments can be forced on a patient, such as ECT, if they're committed to a hospital or if they're admitted in a hospital. You cannot force anyone to participate in cognitive treatments because they are very demanding and they require a lot of they require a lot of commitment from the patient himself or herself. So the patient needs to be motivated. The patient needs to be to demonstrate a lot of commitment if they are a part of cognitive treatments, because they usually require a lot of time. They are they do not really work out as quick as medicines do, or for the matter of fact as ECT does. So you cannot force anyone to participate in cognitive treatment, so they could be considered more ethical. They're difficult to be sure that a psychotic individual has given fully informed consent to any treatment. That again is a flaw, a glitch. Potential risk of physical harm from treatment with ECT. However, ethical issues of consent and withdrawal could be balanced against benefit to the individual in helping manage their symptoms. So on one end, you could say, oh, it's unethical because you're talking about gaining consent from someone who is seen by many as a psychotic individual. But at the same time, as they say, all is well that ends well. You're doing it with good intentions. You're doing it to treat the individual. You're doing it because you understand that the patient might not be in the best of mental state to take the right decision for himself or herself. So along with these issues and debates, you could additionally use more of issues and debates for evaluation. For instance, determinism versus free will. We could always say that ECT reflects a biologically deterministic view, assuming symptoms are caused by brain abnormalities, treatable via electric stimulation. So the patient over here, when you talk about ECT, you can say plays a very passive role. However, on the other hand, we could, when I just write it down to hint you, you could choose to write otherwise as well. So the example that I gave you, I tried explaining how ECT could be considered deterministic, whereas on the other hand, CBT is leaning more towards the free will end, because as individuals are encouraged to identify and challenge their cognitive distortions, this fosters empowerment, of course, and a very active change. So, like this, it says over here, I had just discussed this a minute ago. Yeah, so you cannot force anyone to participate in cognitive treatment, so they could be considered more ethical. So, I mean, let's stick to this part. This makes CBT leaning more towards the free will side. So CBT's emphasis on free will aligns with modern therapeutic ideals, whereas ECT's deterministic perspective is seen as being more reductionist. On the other hand, we could again evaluate this particular evaluate the usage of CBT and ECT as treatments to schizophrenia in terms of quantitative data being collected as well. I'm sure you're all aware both electroconvulsive therapy and cognitive behavioral therapy, they produce a lot of quantitative data in research. For electroconvulsive therapy, symptom reduction is often measured using tools through different validated tools. So is the case with the cognitive behavioral therapy, where cognitive behavioral therapy outcomes are similarly evaluated using scales to assess symptom severity, their functioning, so on and so forth. Likewise, we could talk about how you could again evaluate in terms of subjective and objective data. CBT or cognitive behavioral therapy, they say, excels in collecting subjective data through therapeutic dialogue, because we were talking about now what exactly is CBT. CBT is, in its true essence, a talking therapy, right? So it allows insight into the patient's thought and experience, which of course improves understanding of schizophrenia's personal impact that it has. So you could say that CBT is more aligned towards the subjective side of the debate if you're comparing it with objective data. On the other hand, ECT, however, offers little subjective data as the patient's experience during treatment is very limited. So CBT has a lot to do with talking, and talking has a lot to do with subjective data being collected. Next, we could also evaluate this in terms of the amount of time these treatments require, the cost that is incurred. ECT is considered to be costly and more resource intensive. It requires trained professionals, it requires equipments. However, the sessions are, if you talk in terms of time, sessions are really quick. They require some 10 to 20 minutes in total, and the improvements can be seen to be at a faster rate. They're quicker, they're more rapid. And on the other hand, if I talk about cognitive behavioral therapy, it requires multiple sessions. Like I had said earlier, it is seen to be very demanding. For this, you CBT might often take over weeks or months, and for this you need trained therapists, making it more time consuming, and potentially in the longer run, if you calculate money, the total amount of money being spent, it could be seen to be more costly, perhaps. If we speak about appropriateness, yes, wait, let me highlight this here. So you could say ECT is appropriate for severe schizophrenia. Yes, we've discussed this more so in the last lesson where we were discussing the describing question, the question where we were to describe the usage of CBT and ECT as a treatment for schizophrenia. So ECT is more appropriate when it comes to severe schizophrenia. It works out even better when you talk about, I might as well just write this down just in case if anyone wants to. So appropriateness, yes. So if you talk about ECT, remember we had discussed how it works better for people who have severe symptoms. Remember, we had spoken about how ECT works better with patients who have catatonic symptoms or catatonia. Remember, we had spoken about how ECT is used for patients who are treatment resistant. Treatment resistance shown towards antipsychotics. Well, at on the other hand, if we talk about CBT is more appropriate for a wider range of symptoms, I believe, and stages, but may not be very suitable for patients with severe cognitive deficits because, of course, CBT requires time. CBT is very demanding. So, yes, if the severity isn't much, CBT can work, but if there's someone who you also risk might end up harming himself or herself, then ECT it is, because ECT is rapid, it is quick, and hence, yeah, appropriateness. Moving on towards effectiveness. Let me highlight this again. So as we speak about effectiveness, ECT is effective in reducing severe symptoms in the short term, but shows poor long-term efficacy, right? So for ECT, there is, for short term, yes. For long term, no, it is not very effective. Of course, when you talk about effectiveness, also additionally keep in mind that ECT is usually used alongside medicines. Alongside medicines. And when you talk about CBT, about the effectiveness of CBT has proven to be pretty effective in reducing positive symptoms and improving functioning and decreasing relapse rates when combined with antipsychotics again. So CBT works out. CBT does not have side effects, because of which it is considered to be a better option, but then it doesn't really work well for people who are already showing very severe symptoms. So yeah, we might as well conclude this by saying both electroconvulsive therapy and cognitive behavioral therapy, they differ significantly in their approach, in their ethics, their applicability towards schizophrenia. If we talk about ECT, while ECT is effective for severe treatment resistant cases in the short term, cognitive behavioral therapy, on the other hand, provides longer lasting benefits by addressing distorted thoughts and empowering the patient. Cognitive behavioral therapy also aligns better with ethical standards, the subjective understanding of a particular patient, and it is seen by many as an idiographic approach, which makes it more appropriate and effective for most patients. However, on the other end, electroconvulsive therapy remains a valuable option too, where there is rapid intervention that is required. Like I said, if the symptoms are severe, if you think that the patient might end up harming himself or herself, then ECT it is. So we could combine both the biological and the psychological treatments And by combining them together, we may be able to offer the most comprehensive approach towards managing schizophrenia. Now, a little, uh, wait, I think I want to show you an answer on this. So there's an answer written on this as well. Do not consider this as a model answer. Nonetheless, it is good enough to help you score full. I'll It would take a lot of time if I end up explaining the entire thing, but if you have an idea about the evaluation, this can help you. I'll just scroll this down. You can pause it at any point and try reading through this. This is going to help you understand how to go about with it. What I typically advise students is write your answer into 5 paragraphs, where the first paragraph should be the introduction for aesthetic value. The last should be a conclusion that should be an effective one. The second paragraph, I tell you all that the second paragraph should be about evaluation in terms of the named issue, and the third and the fourth evaluation in terms of any other issue or debate, the last one being the conclusion. Additionally, if you are still watching this, you might as well read through this note as well. So yeah, this is what I was talking about. Paragraph 1 has to do with introduction. Paragraph 2 has to do with evaluation through the named issue. Paragraph number 3 has to do with evaluation through second issue or a debate. Paragraph number 4, evaluation through third issue or debate. And the last paragraph should be conclusion. Bear this thing in mind for any evaluative question, because you have 10 minutes on you. You shouldn't be spending anything more than 15 minutes. You want to pause this here, you want to copy this down, that would really help you. But make sure you are copying this down in one go, so that you know how long it takes you to write this, because in your CIs you would not get anything more than 15 minutes to be able to answer a 15 mark, I'm sorry, to be able to answer a 10-mark question. So yeah, this I hope has been helpful. uh Thank you.